on top of that, we have another drug which I would like to hear a little bit of thoughts on. But before we go to the talk about Ramucirumab, I would like to go back to Catherine. AFP, what's AFP?
That's a great question. AFP is a protein that is released by hepatocellular carcinoma, as well as other cancers it's been reported in, as well as the liver itself when it is injured and regenerating. And I explain it to my patients as AFP is a sign of liver cell growth and regeneration. So for instance, in someone with an acute liver injury, we want to see a high AFP to tell us that the liver is trying to heal. So it has been shown that patients who have liver cancer with a high AFP are a little bit worse prognosis patients, but we also know it's not a perfect test because many liver cancers don't release AFP at all. So it's a tool, but it's only one tool, and you can't hang your hat on the whole story.
Fair enough. With that important introduction, let's put it in perspective. So Tim, back to you. Ramucirumab, tell us the story.
All right, so Ramucirumab is now, I would say, typical vascular targeting agent, antibody targeting VEGF receptor. And it's also tested in HCC, and it also has, similar to actually Carbo, kind of an interesting story because it was tested like many other drugs in HCC, and initially it actually failed. It was used in all comers, and then there was this interesting observation that a subgroup analysis realized that patients with high AFP actually had a much better outcome than the patients with lower AFP. So we decided to repeat this study, and the study was then successfully conducted and showed that in patients with an AFP greater than 400, there is an improvement in the outcome and survival of patients treated with RAM.
And this is the reach too that you're talking about. Catherine, back to your AFP before we ask Mike another question as well. 400, anything magical about the 400?
Nothing really magical. It was, sort of chosen that we've looked at AFP in different cutoffs, whether it's 20 or 100 or 400 or 1,000, and that's sort of a common cutoff that we use and for many studies with advanced liver cancer. For transplant, for instance, we have a cutoff of 1,000 that we, if you have an AFP of over 1,000, we don't proceed with transplant until you get it below 1,000 because of the increased risk of recurrence post-transplant.
Mike, your thoughts on the Ramucirumab vis-a-vis the elevated AFP. Does it mean that maybe, as Catherine is suggesting, that only patients with real advanced disease that are really sick will be the eligible patients for the therapy? Your thoughts?
Well, I'm not sure I would say it necessarily means very sick people, because although it's true, the higher the AFP, at least in somebody who makes it, it tends to be a larger tumor burden. I think the question is there an actual biology behind it? And there's certainly been explanations promulgated that there is something different about the molecular makeup, a pro-angiogenic environment in those tumors that have high AFP. Now, whether that will actually turn out to be the case, it remains to be seen, but at least it offers the possibility that this is more than just a prognostic factor, that it could be an actual biomarker.
No, I totally agree. If anything, I put always those two scenarios. If one of our colleagues from Hong Kong calls me and they say, I have a patient with local disease, resectable, with an AFP of 500,000, I don't sweat over it, because hepatitis B actually is well known to kind of induce quite a bit of activation of the AFP. On the other hand, a patient with AFP of only 100 with stage 4 disease with hepatitis C, again, is very possible. So I think there is a certain complexity to the alpha-fetoprotein that really we don't have yet a full understanding of. And Ramucirumab is definitely there. I would say that the REACH2 showed a clear improvement in survival with the Ramucirumab. The combination of the two studies, REACH and REACH2, which was a pre-planned analysis, definitely shows an improvement in regard to outcome of patients with the high FP, which really reached to kind of the same cutoff of the 10 months or so of second-line therapy as a median survival. But again, as we are hearing here, we're getting a lot of options, which is amazing and probably great news for the patients. Again, to re-summarize the TKIs, we have in first line, we have the lenvatinib as a new advent, which in survival has shown a non-inferiority to sorafenib, but in regard to the response, as we heard from Mike, in regard to the RECIST 1.1 or modified RECIST, it really showed improvement that really reached in regard to the RECIST 1.1, 25 or so percent and 40+% modified RECIST. In regard to second line, it is definitely rather pretty intriguing that we are now have 3 drugs. We put the conditional prior sorafenib exposure, prior tolerance to sorafenib to get the regorafenib. We spoke quite a bit about the robust data of the cabozantinib, which, if anything, can be given in second or third line therapy. And understandably, we've talked about the ramucirumab, and with the conditional exposure that would require a high alpha-fetoprotein, despite our kind of, still not full understanding, probably to be fair, the best we can say, not full understanding of the alpha-fetoprotein to begin with.